Okay, so diabetes, I'm going to come at from a little bit of a different angle, and we're going to talk more about the performance skills that are you could see that will potentially impact overall occupational performance rather than just strictly going over the various occupations and how occupational performance could be affected within those. Because all of um, these factors, these client factors, these performance skills, they across the board could impact all occupation. So first, be sure to do your readings and understand what diabetes is. Again, this is a condition that you will see with many other conditions. Probably, like, you name the condition and diabetes might be a comorbidity to that person or some other, an additional condition that they have. So orthopedics, arthritis, obesity, burns, stroke, brain injury, spinal cord injury, cerebral palsy, uh, people with visual deficits, because visual deficits, vision can be impacted by diabetes. Like, you could see this in anybody's chart, medical chart, you could see diabetes. And some things for you to be aware of that could impact their occupational performance is based on, now you need to do your readings to understand diabetes, but based on the sugar levels, their level of arousal and kind of mental clarity could be impacted. So I'll give an example. How many of you ever get hangry? So, hangry is that interoceptive sense of understanding that you are hungry and angry at the same time. And there could be a component of your sugar levels that have impacted that hangry feeling, that feeling of fatigue, anxiety, fog, anger. So that sugar level has impacted you in such a way that has created this feeling in you. So for people who are diabetic, that also could be something that is challenging for them. So if you're working with somebody who is diabetic, that might be something to be mindful of. If you notice that their arousal is decreasing, or if they like, we're having a conversation and all of a sudden they just start to act differently, more tired. I'm going to use this term loosely with air quotes, loopy, where they just aren't quite themselves. Though that would be an opportunity for you to ask up follow-up questions about, when was the last time you ate? What did you eat? Was it something packed with protein, or was it all sugar? So these are things for you to be aware of when you're working with this client. Because of the fluctuations in sugar levels, there could be not only on arousal, but the memory. So if you are not firing, if your synapses are not firing regularly, and you've got these fluctuations in fatigue and arousal level, how does that impact memory and your functional working memory? So that might be something else that's impacted. So in terms of your interventions, you might be helping them develop strategies for how to, accommodate for impairments in memory based on those fluctuations and maybe arousal or and general overall cognition. We just talked about hangry, so those impairments in the emotional regulation. So if you're working with maybe a juvenile, somebody who has juvenile diabetes, so child diabetes, that might be an area that you are educating them on, or you're educating the family on. So that might be how you're addressing that. Because of the sugar levels, the increased sugar levels, it can impact and cause plaque within the retina. So they might have diabetic retinopathy, which can cause diminished vision. So that might be something to that is something to be aware of when you're working with a client and they're reporting changes in vision. So acute changes in vision, remember acute being sudden versus chronic, which is kind of long-standing. So acute changes in vision, that might be a cue or a clue that their they're having fluctuations in their sugar level, and they need to have their sugars checked, or they need to check their sugars. Or if this is something more chronic, then you might implement some low vision strategies for this person. So if you're seeing them because they've had a stroke, and let's say, and we'll get to this then, but they have visual deficits related to their stroke, but they also are diabetic, and you're in your head, you're like, oh, diabetic retinopathy, I want to double check and see if maybe they have that also in their medical history, because that might compound and exacerbate any new acute vision deficits because of the stroke. Upper extremity range of motion and strength, because again, the fluctuations in their sugar levels, that might be impacted their overall grip strength. Because of the diabetes, they might have circulation challenges, and you might see reduced grip strength because of the nerve damage related to their diabetes. There might be changes in sexual activity, and remember, if you have not heard this already, you will learn and make sure as you read your OTPF that sex and sexuality is within our practice framework. So you might note that somebody who is diabetic might have changes in sexual function. So those might be areas of education. And then if this is somebody who has an acute event, like a stroke or something, stroke or brain injury, or spinal cord injury, where there's also sexual dysfunction, might be part of that as well, but then that added layer of the diabetes. So medication, this is a big one. So as we've talked about, their visual deficits, or the potential visual deficits because of, let's say, the diabetic retinopathy, and then the neuropathy related to impaired circulation, and nerve damage. This could impact their ability to effectively open bottles, grasp little pills, because they'll have numbness and numbness in their fingers, also in their feet. So when you're working with this clientele, because likely you're not working with them because of diabetes, you're working with them because of something else, but they happen to have diabetes in their history, which is also impacting their occupational performance. So if I'm working with somebody who's had a stroke and they need to do medication management, and now they've got weakness because of the stroke, and they've got neuropathy, and they've got retinopathy, I need to take all of that into account as I'm creating my treatment plan and modifying and adapting these areas of occupational performance so that they're able to perform their activities as independently as possible. Now, because of that, I'm going to go back to personal hygiene and then lower extremity mobility. Because of the impaired circulation and nerve conduction, which causes nerve damage, causes the peripheral neuropathy and vascular changes, the nerve damage causes that numbness and decreased awareness of where their body is in space. That's called proprioception. So the risk of injury, especially to the lower extremities, is very high. Because of the circulation and nerve damage, wound healing is decreased. So a client with diabetes is at high risk for infection and amputation. Now let's also go back to functional level of awareness, memory. Because of cognitive changes related to the plaque development and those fluctuations in sugar, their cognition, their functional cognition, their ability to lay down memories, their working memory, attention, this is all impacted. So you will work with clients who have just chronic wound healing. Chronically, you'll see them because they've got impaired wound healing. They're not caring for their wounds effectively, thinking about that cognition, working memory, attention to detail. So let's start with because somebody with diabetes should go to a podiatrist to get their toenails clipped safely. But let's say you meet a client and they had clipped their own toenails and they ended up getting an ingrown toenail. That ingrown toenail, they don't feel it because of the peripheral neuropathy, that numbness in their feet. The circulation is impaired because of the vascular component. So an infection starts to occur. That cognition, they're not really attending to it. They don't feel the pain because they can't feel their foot. And all of a sudden, the toe gets very red and swollen. They go to the doctor and it's got an infection. The infection does not heal. And wound healing does not help. The wound does not heal. The wound does not heal. And then it gets so infected that the tissue dies and they get gangrene. And because of the gangrene, the tissue is dead. They need to have an amputation. So now their great toe on their left side has to be amputated. So you can see how all of those other like client factors, memory, impairments in the nervous system, impairments in the circulation system, are really starting to impact the overall person. So now you are seeing them because they've had this amputation. So you might be doing education on wound healing, like how to care for themselves and do personal hygiene to clean themselves and do skin checks. You're looking at lower extremity mobility, going back to weight-bearing precautions. They might have non-weight bearing on that side, so you need to teach them strategies on how to safely get in and out of the bathroom so that they can, do their morning routine without weight bearing through that leg, how to do skin checks to make sure that there's no further infection. So unfortunately, once there's been an amputation, oftentimes you'll see that person again and again and again as the amputation gets higher and higher and higher up the lower extremity. Unfortunately. So now you've seen them, and prior, during all of this, and this has nothing to do, again, bias can be a big factor here because it's not because they're, socioeconomic status. It's not because of their education level. It's just the nature of the clinical condition that this is just what happens for some people. But let's say driving has now been impacted, and that's their mode of transportation. This is their level of independence. Now you need to give them strategies for being able to drive. Because of the peripheral neuropathy, they might be having numbness and tingling in the lower extremities and the hands that keeps them awake at night. So giving them, you might be giving them strategies for how to manage that pain. Maybe you're talking with the doctor about how to help them with their medications to, help with, you're not doing any medication recommendations, but you might be talking with the doctor about what type of medications they're on, and educating the client on how to use your medications to help with sleep. Participation in leisure activities, going back to all of the other client factors and performance skills that I've already talked about, and how that can impact participation in leisure. And then these are some secondary complications. As I've already talked about, the retinopathy, neuropathy, and amputations. Dialysis is another complication related to diabetes where your client might be on dialysis, and looking at how you as the OT are able to help them with scheduling and transport, how they are able to get on and off of in and out of a car, or how they're able to navigate their environment from at a wheelchair level. Maybe when they were walking before, now they are at wheelchair level and they need to get on the bus to get to their dialysis appointments. So again, you're likely never going to see somebody strictly for diabetes. Diabetes just happens to be a condition that has a very large overarching impact that will then, you need to really consider that when you're working with this client. So I know it was a lot of information. I hope it was helpful. If you have any questions, don't hesitate to reach out.